The city, originally called the City Clinic, was built in 1985. So as clinics, we decided that it's important to change the facility as time has gone by. We've invested quite a bit of financial capital into improving the services that we provide in Soweto. That would be renovating the entire facility. We've recently just opened up our new labour ward, and we've been doing so over the past few years. So we're still seeking to ensure that we create the best kind of facilities for our people within the communities. You know, these facilities were built by the community, for the community, so we'll continuously help to grow and improve.
So we've recently opened our new labour ward, which is now bigger and better, state-of-the-art equipment. The new things that we've included there is the water bath. You know, for women who'd like, you know, water is used also as a form of pain management in labor. So if a woman has a preference, this is a new thing that has been put in our ward, then the woman is given that option to deliver there. We've got new beds that are state-of-the-art when the doctors are delivering their patients without any difficulties. In our new maternity ward, we've included a new nursery, which is much bigger, which has more better equipment, cardiac monitoring of the baby, so that we don't miss any abnormalities on the new baby, because anything can happen. Baby can come, you think the baby is well, can't you? If you don't have the proper cardiac monitors to monitor these babies, you can miss something. And also, you know, we've got neonatologists who works hand in hand with us to manage these precious babies. So those are the things that we've included, and they're working.
Good evening, colleagues. We apologize. We seem to be having a glitch with our video. So Kamo is just looking at it and fixing it. And as soon as it has been fixed, we'll reshare that new video. Because apparently we can't see what's showing. We can only hear the video, but as soon as it's sorted out, we'll reconnect and play that video. But in the meantime, whilst it's still sorting it out, okay, there it comes, yeah. So we'll see if we can, there, thank you very much.
The city, originally called the City Clinic, was built in 1985. So as clinics, we decided that it's important to change the facility as time has gone by. We've invested quite a bit of financial capital into improving the services that we provide in Soweto. That would be renovating the entire facility. We've recently just opened up our new labour ward, and we've been doing so over the past few years. So we're still seeking to ensure that we create the best kind of facilities for our people within the communities. You know, these facilities were built by the community, for the community, so we'll continuously help to grow and improve.
So we've recently opened our new labour ward, which is now bigger and better, state-of-the-art equipment. The new things that we've included there is the water bath. You know, for women who'd like, you know, water is used also as a form of pain management in labor. So if a woman has a preference, this is a new thing that has been put in our ward, then the woman is given that option to deliver there. We've got new beds that are state-of-the-art when the doctors are delivering their patients without any difficulties. In our new maternity ward, we've included a new nursery, which is much bigger, which has more better equipment, cardiac monitoring of the baby, so that we don't miss any abnormalities on the new baby, because anything can happen. Baby can come, you think the baby is well, can't you? If you don't have the proper cardiac monitors to monitor these babies, you can miss something. And also, you know, we've got neonatologists who works hand in hand with us to manage these precious babies. So those are the things that we've included, and they're working perfectly.
Good evening once more, colleagues, and thank you for joining us at this weekly webinar brought to you by Clinics Health Group. And we're excited to be bringing another presentation from one of our host committee members this evening, who's also a top academic and quite an experienced clinician. But just want to welcome all of you and say, please make sure that when you log in, you provide us with when you register actually, you provide us with your full details, say name, surname, and your practice or a registration number in terms of your HPCSA or National Council of Nurses, and also Pharmacy Council or allied health professionals. And if you're not a registered healthcare professional but working in the healthcare industry, you're also welcome to join us at these webinars. And please note that these webinars are CPD accredited and also streamed live on YouTube, so that at any time you want to go back and watch this presentation, you are at liberty to do so at your own time. And don't forget to mute yourself and also switch off the video. And at the end, or during the presentations, you are free to post questions in the chat box, so that at the end of the presentation, we're able to take these questions and request the speaker to address them. And your comments are most welcome. And we trust that we'll have a wonderful time this evening once more as we engage in this presentation by Professor Jeff Wing, who's coming back, I think, for the second time or third time, these presentations, and he's going to be talking to us on pulmonary thromboembolic disease. And is a specialist physician and also an endocrinologist of note. And so we just want to welcome Prof. Jeff Wing. I do not want to go through the whole CV or brief bio that we've shared with you. And we are excited to have him once more joining us this evening. So thank you very much, Prof. Wing, for being with us this evening once more.
Thank you, Dr. B. I'm just going to try share my slides now. Let's see. Right, can you, are my slides clearly seen by everybody?
Not yet showing.
Okay, so I'm going to start. So I thought I'd give a fairly concise lecture, review on pulmonary embolic disease.
Sorry, Prof, you can't see the slides.
Not yet, it's not, the slides not yet showing.
Oh, gosh.
Hi, Jeff.
Hey, Dr. Bila.
Prof, are you still there?
What's hearing here? I'm not
Hi, Prof.
sure come who can help me.
Yes, can you please click on share screen?
No, not yet, not yet.
Such a beautiful evening, right?
Prof, are you still there?
We're trying to see how we can resolve this. Prof. Wing will send me the slides and I'll share from my side. Go. You seem to be
Okay,
having
no
a
problem.
challenge on this side for some reason this evening.
Okay.
Just admit, colleagues, Kamu, we are trying to get Prof. Wing to send the slides to me so that we can share from our side.
Okay, Dr. Bila, noted.
Yeah. Yeah, just a few apologies, colleagues will, as soon as it's sorted out, we'll do so. I see there's something coming through. Hi, Kamu, can you say this? Can you see this the screen I've shared now?
Yes, Dr. Bila, can you please do a slideshow?
Okay. I was also waiting for Prof. Wing to join us.
Okay.
He's rejoining us, and I will. Okay, can you see it now?
Thank you. That's okay.
Okay, thanks. We're waiting for Professor Wing to join us now. Are you in? No problem. Sorry, colleagues, we still, Prof. Wing still has problems with rejoining, but as soon as he has sorted out the gadget problems, he will rejoin us. But he's busy. The system is still doing some checks, some compatibility checks with this laptop that is using today. For some reason, it has worked in the past, but tonight it's giving us a problem. But as soon as it's sorted out, we'll rejoin. No problem. Hi, colleagues, Prof. Okay. Come Bruce, Prof. Jeff Wing and work with him to assist him, sure. Colleagues, in the meantime, we having some glitches with Professor Jeff Wing's laptop. He had logged in earlier on, everything was working quite well, but for some reason, when we were supposed to start the presentation, it didn't work. So we are working, trying to sort out the problem to see what the issue is. And then as soon as it's been sorted out, he will log in and rejoin us. We've got the presentation. We thought that was a problem, that he couldn't move the presentation. But now he logged off and he's unable to, he's having challenge to log in. But we'll have that sorted out very soon. Just to remind everyone who is logged in that please do make sure that you provide us, I think it's coming in now, give us the full details about yourself so that we're able to send you information. There have been some colleagues who've had issues with the certificates, but if you're having a problem, please do not hesitate to send us a message at webinars@clinics.co.za or send it to me direct at rbila, Bila @clinics.co.za. We'll see what we can do. And we do liaise with the HPCSA who do look into checking your certificates if your information has been uploaded or not. But we are told that there has been some backlog with HPCSA. So if you find that you are not able to, you're not getting your certificates, know that they will be sorting it out very soon, as soon as they've cleared the backlog. We seem to be having challenges once more with Professor Jeff Wing joining. I can see he's joining in, but it's taking a while before he can join in. We'll see how we can resolve this matter, but do not lose patience. And we've done it before. We shouldn't be having problems with this one once more. But it will be sorted out. We do have the presentation, and so the information is available just for the speaker to go through that with us. Seems to be hanging on this side. Sorry. Oh, sorry. I was muted. I was talking to myself and Professor Wing. What we have decided that Professor Wing will speak on this side and I'll run the slides for him. If you could just confirm if you can hear Professor Wing. Can you hear him, Kawi?
Hello, everyone. Can you hear me?
Yes, it's a bit faint, but I can hear him. I can hear him, yes.
I'll shout a bit. So if I talk too loud, please stand up. Okay, wait, you want to see the slides?
Yeah, I've started sharing this. Okay, we are on the first slide. You can go ahead. I don't know.
I can't see the slide.
Oh, you can't see the slide?
No.
Oh.
Dr. Villa, I think Prof can open his laptop and
Oh yeah,
see the slides
open your
from his
laptop. Just don't worry. Open your laptop.
Yes.
Just open your laptop. Work from your laptop. You don't have to share from. Work from your laptop.
Okay, great.
Yeah.
Okay, so Ray, go to the first slide.
Yes, I'm there. PTD outcomes a success story.
Please, everyone. I hope you can all hear me. I'm going to talk loud and I'll talk efficiently. So, pulmonary embolic disease currently is a medical success, unlike my laptop and technology. So, apologies for that again. So, as you can see, the incidence of pulmonary embolic disease has risen over the decade, 1997 to 2013, and yet the mortality from this usually severe disease has decreased dramatically. And this is a worldwide phenomenon. So obviously we're doing something right as clinicians in terms of diagnosis, in terms of risk managing the patients or triaging the patients into risk categories. And obviously last but not least, in terms of management that we offer. Okay, next slide. Okay, so success is simple. We must do what is right. We must do it the right way, and we must do it within the right time frame. So what I want to do is offer a clinical presentation, not a lot in terms of what the clinical signs and symptoms are likely to be. Look at the at-risk patient, so try and integrate a clinical picture of the entire patient. Look at the investigations briefly, and then spend some time on specific therapy. Okay, so history. Next slide, Ray. So as with signs and symptoms, they're often insensitive and relatively non-specific. So most of us would recognize that a cluster of symptoms and signs would often only give us at best a 20%, 25% diagnostic accuracy in terms of sensitivity and specificity.
But having said that, we mustn't neglect it because it does point to clues of what we should be doing. So, hemoptysis, dyspnea, chest pain, as you can see, are not specific or sensitive. In general, they occur in only 20% of patients in whom the diagnosis of a pulmonary embolus is subsequently made. Just advance, Ray. But just on the history again, those who go on to die, this is post-mortem studies, these are patients who've had a massive pulmonary embolus. Retrospectively, 60% of them have had dyspnea. So while symptoms are inaccurate in terms of sensitivity, specificity, we must still acknowledge that they're still important. And particularly in the massive pulmonary embolus, seemingly dyspnea is important. Okay, next slide. So obviously, people that succumb to pulmonary embolic disease or who develop it, usually develop it deep vein thrombosis. So this is data from SMJ, looking at the type of procedure and illness that patients tend to get admitted for in hospitals and what their risk of DVT is. So prevalence of DVT going from 10 right up to 80%. So if you look from the bottom and go up, you can appreciate that it's related to the type of surgery, in medical patients to whether they're relatively immobile, whether they're in ICU. But in general, you can see as the surgery becomes more involved and more major, the prevalence of DVT rises. Ray, advance. And at the same time, if we then look at patient factors in terms of DVT, elderly patients, patients that are immobile, obese, heart failure, autoimmunity, HIV, inflammatory bowel disease, cancer, pregnancy, estrogen therapy, and obviously inherent clotting abnormalities. These would all predispose the patient to a DVT. And if we superimpose duration of admission, and if there's a procedure to be done, the degree of tissue damage that's anticipated, one can almost predict that patients are likely to fall into the 80% prevalence rate for developing a DVT while in hospital. Next slide. If you then look at thromboembolism, so we now move from a DVT, a simple DVT, uncomplicated DVT, to thromboembolism. And if we look at medical and surgical patients respectively, this again says it in a different way. High risk, polytrauma, orthopedics, major surgery, operations related to cancer. Moderate intermediate risk in terms of surgical patients, immobilization, arthroscopy, and in terms of duration of surgery, more lengthy surgery. Low risks of pulmonary embolus is minor surgery, less than 30 minutes, where there's little or no tissue injury, and medically the patient has little or no risk factors. Now, often patients have both surgical issues to appreciate, and often this is a background on medical illnesses that the patients may or may not have, the comorbidities. So again, high risk, patients in ICU, sepsis, stroke, ventilators, major cardiovascular risk factors, moderate risk in terms of medical background, heart failure, cancer, infections, other inflammatory diseases, bed rest. And low risk is basically patients who are more ambulatory and with little or no cardiovascular risk factors. So obviously, if you look at these two diagrams, you can see that, for instance, there's a patient who's got cancer, who's got obstructive airways disease from a medical point of view, and now has to have major surgery. This patient's risk is exceedingly high. Next slide. So Often we miss out on the basics. A simple ECG is often helpful. This is often useful for the clinician who's going to interact with the patients in the first instance, i.e. casualty officers. So the typical S1, 2, 3, T3 changes on ECG tend to occur with massive pulmonary embolic disease occurring in the patient. And you can see in this ECG, the S1, the Q3, and inverted T in standard lead 3. Okay, advanced array. But most importantly, the most common change, cardiovascular change with pulmonary embolic disease is a simple sinus tachycardia. So the patient presents with vague respiratory symptoms, has a sinus tachycardia, with or without the ECG changes of acute call pulmonale. This would still indicate clinicians at first call particularly must have high index of suspicion for pulmonary embolus. Okay, next slide. X-rays are useful, but again, non-specific. And this is usually important because often the massive pulmonary embolus has usually fewer changes apart from oligemia. And this is often difficult to appreciate. The smaller pulmonary embolus has non-specific changes as well, as you can see there. So chest X-ray useful, but not really sensitive or specific. Perhaps useful for excluding other causes of dyspnea. Okay, bedside investigations that are useful, and I mentioned these, the D-dimer, because it's often available as a point of care test, and many casualties today would have access to this point of care test. So the D-dimer is important in that if it's negative, the likelihood of the pulmonary embolus is extremely low. So it's useful for excluding a pulmonary embolus in a patient with respiratory symptoms. Okay. So, of a D-dimer test. Okay, Ray, next slide. So what's emerged now is the issue of looking at biomarkers of these right heart strain, myocardial injury, TROP-Ts go up, and if there's right heart dilatation, then the pro-BNP goes up as well. So these are very useful when it comes to stratifying patients at risk for high mortality from pulmonary embolic disease. And again, I mentioned these two tests because they can easily be accessed in the lab or even via point of care cot. They're useful to do. Okay, here we go. So Ray, next slide. So this one is a CT angiogram. So the gold standard now for diagnosing pulmonary embolic disease is a CT angiogram. And as you can see, that arrow is pointing deficit, which indicates a large thrombus in the pulmonary artery. So CT angiogram is the gold standard currently. If there's a pulmonary infarct, you can see this on your left, next to the cardiac shadow. That's what it would look like on the angiogram. And the next slide, at times, the V2 scan is still very useful. Again, a normal V2 scan is particularly useful in excluding a pulmonary embolus. And it's a little bit insensitive when it's underlying chronic pulmonary disease, such as COPD or even heart failure, but still a useful investigation. And I'll mention this again in terms of chronic disease. Okay, and again, value is that if the scan is normal, one can safely exclude a pulmonary embolus. Ray, next slide. So what's coming to the fore now is that One is looking for evidence of tissue damage in terms of right heart strain. And almost certainly now, cardiac sonar in the setting of embolic disease is becoming a very important investigation. And here we're looking for RV pain, enlargement, hyperkinesis, etc. So a very useful test. Most medical schools, what they're doing now, we're developing courses to teach medical students to carry little sonar probes and do very basic sonography. And this is one of the reasons in the future, most of us would be carrying a small sonar probe when they're doing diagnostic. That would be particularly useful. So I'm particularly looking at life, heart, brain, and disease. Brain, next slide. Next, most of the investigations. So we've got the clinical picture. We understand what procedure the patient is coming in for, whether it's long, short, major, minor surgery. We know a lot about the background of the patient's medical history. So importantly now, we can risk stratify the patient. So currently, high, intermediate, and low risk is the way we would assess patients. So let's look at high risk. If there's shock or hypotension, and if there's signs, sonographic signs of RV dysfunction, this patient is high risk. So just those two parameters. If there's cardiac laboratory biomarkers, the TROP-T and the BNP, if they raise, that's helpful as well, but you don't need it. And if you do a score, which I'll show you later, the pulmonary embolus, what's this, risk index, and modified one, which is at the bottom. Simply, I'll show you how to do this later on. It's very simple. We can score this patient in terms of high, intermediate, and low. So intermediate scoring is largely dependent on that scoring system, which I'll show later. And again, evidenced by RV dysfunction or the presence of cardiac biomarkers. If you look at intermediate low, there's no shock, no hypotension. The scoring chart scores positive, and RV dysfunction or cardiac biomarkers may or may not be there. A low-risk patient would have very little of all those four criteria to diagnose and a very at-risk patient. So Ray, just advance. So this is a simplified way of scoring who's at risk for pulmonary embolus: age, heart rate, low blood pressure, low SATs, and underlying medical diseases, cancer, cardiovascular, or respiratory. So this is a simplified pulmonary embolic index. And if patients fall into that, you can give them a high score. So this is a useful strategy to scoring patients. Okay, Ray, next slide. So when we talk about treatment, obviously what we're trying to do is balance the benefit of bleeding versus the actual treatment of the pulmonary embolus. And this applies to all diseases, the risk-benefit ratio. Next slide, Ray. So I don't want to go through this in too much detail, but this is our old physiology in terms of the clotting cascade, the intrinsic and extrinsic pathway. Just to show you where warfarin works, so vitamin-dependent clotting factors in the liver, so it inhibits that. Factors 2, 7, 9, and 10. That's how warfarin works, and we've been using warfarin for many decades. We've also been using heparin for many decades, and perhaps over the last 3 decades, low molecular weight heparin. Where that works, it inactivates factor 10 dependent conversion of thrombin to prothrombin to thrombin, and hence prevents the cascade of fibrinogen going to fibrin. So at the bottom, that's how warfarin works, and we use it a lot. And at the top, low molecular weight heparin, that's where it works. Ray, next slide. Okay, so heparin shown again in terms of thrombin activity. The newer agents, these are the non-warfarin oral agents. And as you can see, there are direct agents and indirect agents. So the direct agents, those are the 4 or 5 medications working specifically within the cascade, factor 10 activation, factor 2 activation, and the indirect oral agents working primarily at the tissue factor pathway. So they inhibit damaged tissue, which activates the clotting cascade. Don't forget 2. So I've mentioned the warfarin, I've mentioned the heparin, I've mentioned the newer oral agents, non-warfarin oral agents, non-vitamin K dependent oral agents, 2 subclasses, a direct and an indirect subclass that work differently. And last but not least, we have fibrinolytic agents that actually chemically lyse fibrin. Okay, so, and that's an example of a fibrinolytic inhibiting plasma or activating plasminogen to plasmin, and hence clot lysis. Okay, so that's a little bit about the basic physiology of where anticoagulation therapy works within the intrinsic and intrinsic pathways. So with that risk stratification, I think the important thing here is if you, the clinician, and you first call and you're attending to the patient as the initial clinician, the important thing, the first decision you need to make is whether this patient is in shock or not, so a high risk for death from pulmonary embolus. And if that's the case, obviously do the investigations, but you would consider fibrinolysis or in fact surgical embolectomy. If there's no shock, we can follow that previous slide that I showed and risk stratify the patient in terms of what you're going to do, the investigations. Remember, the sonar to look at right heart strain, and the tissue markers to look at early cardiac necrosis and right ventricular dilatation, and then choose anticoagulation alone. Right, next slide. Okay, so the important thing there is to remember, if there's shock, consider fibrinolysis. Right, so systemic fibrinolysis, patient shocked, green light, patient should deserve this. The downside is intracranial hemorrhage. So in terms of that risk stratification, if the patient is hypotensive, it's quite easy to make that decision. If the patient is not hypotensive, then don't offer fibrinolysis and use conventional heparin because of intracranial hemorrhage. That's a dose of the fibrinolytic agent that's the most popular, 30 to 50 milligrams in a normal weight patient, and half the dose if the patient is greater than 75 years. So this is for systemic fibrinolysis. Right, so what's the evidence that this is useful? So meta-analysis mortality reduction, 30%. PE-related mortality reduction, 29%. Recurrence reduced by 50%. However, major bleeding overall increased by almost 200%, and intracranial bleeding by a factor of almost 300%. So threefold, fourfold increase. So that's the downside of systemic fibrinolysis. So with that in mind, what about other options? So there's been some work done to say, well, if we're worried about bleeding, should we not just offer systemic fibrinolysis and use a lower dose? So pretend that everybody's over the age of 75, offer systemic fibrinolysis and treat the patient that way, and try and balance the risk of bleeding, especially intracranial bleeding, with the ability to offer fibrinolysis. So the verdict is out on that one, whether low dose fibrinolysis works. So not really a class 1 recommendation. However, number 2 is important. And I think 2 or 3 weeks ago, we had a great lecture by, I think, Dr. Medisi, an interventional radiologist, and where he discussed catheter-directed fibrinolysis. So this is much safer in terms of avoiding bleeding, particularly intracranial bleeding, or bleeding elsewhere. And I'm happy to say that the clinics group is able to offer this. So the primary clinician working with radiology and an interventional radiologist. So this can be done. Last but not least, in some patients, formal surgical thrombectomy may be indicated, but the indications are really small with the advent of catheter-directed fibrinolysis. Next slide, Ray.
I'm not sure if I'm with you. I'm on the systemic
Just for
fibrinolysis.
completeness sake, is that surgical intervention, again, in some patients, deserve filters, to have filters inserted in the inferior vena cava to prevent recurrent pulmonary embolic disease from lower vein thrombosis, usually iliofemoral. So a small indication for these, but much rarer today. Okay, so here's heparin. 1 milligram per kilo, twice daily, standard dose. So this is for patients not needing fibrinolysis,
Sorry, Jeff,
either
I'm not sure.
systemically or
Hi,
by
Jeff.
catheter-directed modalities.
Jeff, sorry to disturb you. I'm not sure which slide are you on.
The question is now whether we can replace heparin with the with the newer oral anticoagulants, so the non-vitamin E, non-vitamin K antagonists. So, as you would all know, previously the gold standard was heparin. Start warfarin almost simultaneously. After 5 to 7 days, wean off the heparin and continue with warfarin. So the question is whether currently we can do this without heparin and without warfarin. So there is evidence now, 1A evidence, that the newer, the NOACs, non-warfarin oral anticoagulation is effective and is preferable because of the bleeding issues, less bleeding again, to vitamin K, in other words, to warfarin.
Hi, Jeff. Sorry to disturb you.
So here we are. So here are the 4 agents again.
Jeff, can you hear me?
They have been shown to have equivalent efficacy with far less bleeding. INRs we don't need intensive monitoring with INRs. Studies now indicate that they're effective in pulmonary embolic disease, in proximal DVTs, in thrombotic stroke, and even in myocardial infarcts. They're useful too cancer patients who are at risk for clots, for chronic pulmonary embolic disease, and in patients with AFib. The only patients that we don't use them in are pregnant ladies, patients with the antiphospholipid syndrome, because studies in this group of patients, when in pregnancy, the safety is uncertain, but in patients with antiphospholipid syndrome, the effect isn't been well documented. And in fact, warfarin in this setting may be more efficacious. And no one really wants to do a study in patients with prosthetic valves. So pregnancy, APL syndrome, prosthetic valve, patients with prosthetic valves use warfarin and not the newer agents. Obviously, the other issue with these newer agents, which are easier and safer to use, is medical aid constraints, because they're far more expensive than heparin and warfarin. Next slide, please, Ray. Okay, so that was just to remind you that don't use it in those three categories of patients. Okay, next slide. So this is just to show you that the newer agents compared to warfarin are far, far safer in terms of major bleeding, all bleeding, including gastrointestinal and intracranial. So they are an advance in terms of risk profile. Next slide, Ray. Also, in terms of safety, there are monoclonal antibodies that have been developed that are able to inhibit these newer agents in the event where patients bleed while on them. The effect of these agents can be easily reversed. So the safety margin in terms of reversing excessive bleeding can be managed. Ray, next slide. Okay, so this one is too busy, but it just summarizes what I've said up to now. So the top line, we have a clinical assessment, we have a diagnosis, we stratify the patient, we offer treatment, and then we consider long-term or short-term treatment. And I'll come to that later on. The middle panel tries to say, well, let us risk stratify the patient. Let's score these patients. So it guides us to what to do. And it also tells us what ancillary investigations we need to look at. I mentioned these CT scan, the use of echo and right heart disease and tissue biomarkers as well, the TROP-T and the BNP. The VQ scan is useful in terms of deciding on chronic treatment. When we stratified the patient after our clinical assessment and investigation, we can decide on what anticoagulation therapy and what format to use. We obviously have to balance the effect of adequate anticoagulation versus bleeding. We have to consider the patient who is at risk for recurrent disease, and last but not least, those patients who are likely to develop pulmonary arterial hypertension. At the bottom, summarize the two slides I showed you earlier in trying to integrate surgical aspects of patient profiles with the medical. And we mentioned what sort of surgery, minor surgery versus major surgery, duration of surgery, the status of the medical status, medical background status of the patient, and last but not least, the age. So this is just a useful summary of everything I've said up to now. Ray, next slide, please. Okay, so the last question that often arises is, do we go on for 12 months or 6 months or shorter? So the issue there is, again, look at the background of the patient and decide whether a patient needs short-term treatment, 3 to 6 months, longer-term treatment, 12 months, or indefinite treatment, in other words, lifelong. So a provoked embolus would be someone with a surgical procedure, immobilized, someone with a profound medical background that is prothrombotic, such as patient with a cancer, probably needs indefinite anticoagulation. And where we're not sure, we would treat for 12 months. Next slide. Oh, Ray, just before you change over to the next slide. So the VQ scan is very useful in deciding duration of treatment. So obviously, if after a short course of treatment, say 3 or 6 months, a VQ scan is done, and this still shows pulmonary embolic disease, or newer disease occurring, newer perfusion defects evident on the VQ scan, then obviously this patient is eligible for indefinite treatment. Okay, next slide. Right, so the last 2 or 3 slides is a comment on pulmonary arterial hypertension. So obviously pulmonary embolic disease, chronic, especially chronic pulmonary embolic disease, is one of the major causes of pulmonary arterial hypertension. And like systemic hypertension, we have started to address this as a factor to reverse. So reduce pulmonary arterial hypertension in the setting of chronic disease, chronic lung disease, including pulmonary embolic disease. Ray, next slide. Okay, so this is just to show you options. So obviously in medicine, we always say treat the cause, right? The cause of the DVT and the pulmonary emboli, try to do that. Treat the condition, which is the pulmonary embolus. We're going to anticoagulate. We may do it long or short. We may use warfarin, or we may use the newer agents. So that's treating the condition itself. And the last C, treat the complication. We'll be aware of the complications. So cause, condition, complication. And in this case, the major complication is pulmonary arterial hypertension, which leads to right heart failure and obviously cardiac mortality. So as you can see here, randomized studies to say, if we reduce pulmonary arterial hypertension, mono, dual, triple combo therapy, I'll mention these later on, this is what happens. So the story here is that for high-risk patients and intermediate-risk patients, this is worth doing in terms of survival rates after 10 years. And what seems to be the message here is that for the high-risk patient, we need triple therapy. And for the intermediate risk patients, we need triple therapy. So the concept here, much the same as systemic hypertension, we often need 3 medications that are able to reduce pulmonary arterial pressure. Ray, next slide. So these are the ones working on the endothelium pathway, so antagonists of vasoconstriction. So these are the agents, all FDA approved. We all know about the phosphodiesterase inhibitors. So these are used now for pulmonary hypertension. And last but not least, a new class of prostacyclin drugs that promote vasodilatation. So one would offer triple therapy in those patients at high risk for pulmonary arterial hypertension. Okay, so obviously here you would have to refer patients to a pulmonologist, cardiologist, right heart caths would have to be done, measured, and there's a whole scoring system again of how you manage these patients. Okay, so last slide, take home. I talked about a good story, a successful story. I shared some of the data that allowed us to get to this point. And within the clinics group, I hope we will continue to be part of this world global success story and be aware of offering our patients better diagnosis. We must stratify patients into their different risk profiles, pick the right patient, and get a clinical team to a multidisciplinary team, obviously, to assist with that. And this particularly refers to where we need thrombolysis or even surgical procedures for patients with pulmonary embolic disease. Ray, my last slide, please. Yeah. So you can advance. So we don't want to end up in this position with a lot of M&M meetings where this poor patient's brother died of a pulmonary embolus. So thank you. Apologies again for the delay and for the technical hiccup. And I'm happy to try answer questions via Ray.
Okay,
Thank you very much.
Thanks a lot, Jeff. I hope that we'll be able to do so. I was trying to talk to you much earlier. I hope you can hear me.
Yeah, I can hear you.
Okay, so Jimmy's still here.
Yes.
Okay, thanks, colleagues. I hope you can all hear me. And apologies for the glitch that we had, but we managed to present the slides and the talk by Professor Jeff Wing. And thank you very much, Jeff, for this, and colleagues and those who've been trying to help us. But you will be able to, I think, go back and watch. We'll share the slides, I think.
Yeah.
Yeah, sure.
Pleasure.
Yeah. And for those who are trying to send me questions directly to me via WhatsApp, I'm unable to multitask. I'm sorry. So
My fault. My apologies.
this is actually double multitasking. So I'm able to look at the questions on my phone and ask you. So please do. Camille also have to help me. Perhaps I will have to stop sharing. That would help me to manage this much better. Okay. So I'm going to ask if there's anyone who's got a question for Professor Jeff Wing. Please do so. You may raise your hand, I think, obviously on the system, or just post your question on the chat box. I'll try and see if I can see if there are any questions for you, Jeff.
Okay. Thank you.
They seem to have disappeared. Gamu. Thank you. I think, yeah.
Hi, Doc. I'll forward you the questions just now.
Oh, okay. Not sure. Is warfarin not contraindicated in pregnancy? One of the questions.
Yes, it is. Definitely. Pregnancy, heparin only.
Okay. And then there's a question here: is Xarelto more cost effective than warfarin? Well, maybe let's deal with that one. There's a follow-up question to that one.
Okay. So the answer is it's easier to use and less complicated. However, medical aids often price warfarin against it, and obviously it costs nothing. Warfarin costs nothing. But if you've got a high-risk patient who's at risk for bleeding and needs PIs every week, in the long term, it may be cost-effective.
Okay.
So that's the motivation. I tend to try right to medical aids, and some do accept it, some don't. Often I enlist the help of a hematologist to say, what do you think about using more expensive items?
Okay. Then the second question, you do a Doppler and find chronic DVT after a patient has completed 12 months of warfarin. Should that patient be on lifetime warfarin?
So if the DVT is cough, the answer is probably not. If it's iliofemoral, the answer is probably yes, because the latter embolizes much more than the cough DVT. But the right answer there would be do a VQ scan. And if there are still perfusion defects evident, then this patient needs lifelong treatment.
Okay. And the third question from the same Dr. Totet is that issues with bleeding on fibrinolysis. Should we take the same approach when we encounter STEMI, meaning that we don't use fibrinolytic drugs when non-STEMI patient is stable? That's a normal BP.
Yeah, so the answer is the only absolute indication is if the patient is shocked. If the patient is shocked, that's a massive embolus. And obviously, if those biomarkers are positive, the TROP-T and the BNP and the echo says there's right heart strain. But the main issue there is if there's shock, then no one will argue with you that the risk of the fibrinolysis, the systemic fibrinolysis, probably outweighs the risk of bleeding.
Okay. Yeah, there's
Because you're trying to save the patient first. Yeah, the first prize is to save the patient.
Save the patient, yeah. Okay. Here the question is not so much related to the talk. The person says, can you please comment on this, especially aneurysm suspicion, although I know the Zoom is not about aneurysms. Or when you suspect there's an aneurysm, what do you do?
All right, if there's an aneurysm, very, very hard to anticoagulate, whether it's, so you don't offer fibrinolysis if you suspect an aneurysm. Even then, you would be wary of offering heparin or warfarin because this patient is at risk for bleeding. So if there's a definite aneurysm or aneurysm highly suspected, then the patient almost certainly is going to die of the treatment.
Okay, yeah. We're going back to COVID.
Yes.
There's a very prevalent feeling that COVID was responsible for the increase in pulmonary embolic disease and more for the high incidence of cerebral and other aneurysms. Is that a fact?
Answer is yes. So remember, COVID, part of the COVID syndrome is systemic vasculitis. Vasculitis everywhere. So whether it's in the brain or other organs, there's lots of vasculitis. So the answer is definitely yes.
Okay. Thank you. I'm looking for another question. I think we dealt with the Xarelto question. Patient, yeah, there's a patient who was found to have a chronic thrombus in the left pulmonary artery on CTPA,
Yes.
but
Yes.
no acute thrombosis, no copulmonale on echo, but copulmonale to articulate. I'm not sure. Do you anticoagulate or don't you?
So it has got copulmonale and has got a clot.
Yes, there's a thrombus in the left pulmonary artery.
The answer is yes.
Chronic thrombus.
This patient may even be subjected to fibrinolysis via catheter.
Yes.
Yeah. Yeah.
And then the question, it's a combination, PE and SLE and warfarin. Can you put the...
Yes. So the answer, SLE is very closely linked to the antiphospholipid syndrome. So definitely warfarin versus the newer agents. Answer yes.
Okay. And lastly, should we screen patients for PE when they have a PTB?
Difficult one. Unless there's a clinical, so the VQ scan would be inaccurate. The tissue markers would be inaccurate. So one would have to go here on the issue of, has the patient got a source? That's what I would emphasize. If this patient has got a source of emboli, DVT, iliofemoral disease, then the answer would be yes. Because the other tests would tend to be a little bit inaccurate. Lots of false positive, false negative results.
Okay.
A pulmonary angiogram would be accurate, though.
Yeah, yes.
That's a CT angiogram.
CT angiogram, okay. This doctor says, I've seen a specialist not giving warfarin when patients have settled PE. Why is that? When they've got a settled PE and they are not put on warfarin?
So I think in that instance, that if it's a saddle embolus, that patient and the patient is shocked, one would have to say, this is one of the areas where surgery may be indicated, embolectomy, if the doctor was angling towards embolectomy, if the doctor was angling towards fibrinolysis. But at any rate, if he wasn't contemplating either of those two, for whatever reason, then the first the first call of treatment would be Clexane, would be heparin, which is only and then followed by warfarin, but not warfarin at the onset.
Okay. I hope Dr. Sotetis has been answered. Sure, we managed to pull it off, Jeff, under the difficult circumstances.
Please
No, nobody's aware that there's a problem. You've been here before and we never had glitches. For some reason, something has happened tonight.
Yes. Yeah. I'm going to church this weekend and I'll try to sort it out.
Yeah, me too.
In the future.
Okay. I'm going to ask, I'm not sure, I hope Prof. Langon is still connected. Prof. Langon, if you're still connected, just your last words on this before we log off.
Jeff, that was a superb refresher for a lot of us who haven't looked or read up on the subject for a long time. So thanks very much. I enjoyed it despite the early glitches.
Yeah.
Thank you. Kind comments. Thank you very much.
Thanks, Prof. Langan, and thank you for being part of this discussion and for also helping on the sidelines with the slides. Thank you, colleagues. Thank you very much. We made a wonderful presentation. I think quite but many things have happened tonight, but we managed to put it off, and thanks, Jeff, for being able to do so. And I want to thank all of you for sticking up until the end, and we would definitely share the slides with you. And Kamo, the background, and Anza, thank you very much for assisting as always. And thanks a lot to Jeff Wynn for this presentation, and we look forward to another exciting and less dramatic presentation in the future.
Thank you. Thank you.
Thank you very much. And good evening, colleagues. So, okay, bye-bye. Bye. Bye.